Good afternoon, everyone, and welcome. I'm Philip Osteen, Dean of the University of Utah College of Social Work. It is my pleasure to welcome you to this Social Work Beyond the Classroom presentation. These presentations give us the opportunity to delve into the work that engages our faculty members outside of their teaching duties and to provide additional learning opportunities for students, graduates, and others in the community. We are pleased to welcome a very large virtual audience today. Thank you for joining us live, as well as to those of you who are watching this recording at a later time. I want to note that we will be discussing suicide today, so I encourage you to be attentive to your own well-being and needs. And if you need to step away for a minute, please do. If you feel the need to log off and watch the recording later, this video will be available to you. I also want to express my sincere gratitude to everyone who donated while registering. These donations will go toward the BSW Field Fund Scholarship, which supports our bachelor students during their practicum placement. This is actually the fund that I've chosen to support during next week's Youth Giving Day. If it's something you're interested in supporting, I also encourage you to check out Giving Day on our website. To everyone who donated today and next week, thank you for your generosity. Before we get to the presentation, on behalf of the College of Social Work, I want to begin by acknowledging that this land, which is named for the Ute tribe, is a traditional ancestral homeland of the Shoshone, Paiute, Goshute, and Ute tribes. The University of Utah recognizes and respects the endearing relationship that exists between many indigenous peoples in their traditional homelands. We respect the sovereign relationship between tribes, states, and the federal government, and we affirm the University of Utah's commitment to a partnership with Native nations and urban Indian communities through research, education, and community outreach activities. Today, we'll learn how Assistant Professor and Lecturer Josh Kivlovitz weaves evidence-based care into his work as a licensed clinical social worker, specializing in treating individuals facing chronic suicidality, non-suicidal self-injury, and borderline personality disorder at his practice, Wise Mind Behavioral Therapy. Professor Kivlovitz earned his Master's of Science in Social Work from the University of Texas at Austin and has worked in a variety of community mental health and private practice settings with adolescents and adult clients. He is a dialectical behavioral therapy Linehan board certified clinician and has additional expertise in behavioral therapy interventions, including acceptance and commitment therapy and prolonged exposure. Outside of his educational and clinical work, he is involved in community organizing efforts to reimagine pretrial incarceration with the Salt Lake Community Bail Fund. Please use the Q&A function at the bottom of the screen to submit questions, which Professor Kivlovitz will take at the end of his presentation. And with that, Josh, the virtual stage is yours. Thank you.
Thank you so much for that introduction. Welcome, everybody. I'm really excited to dive into this training. I took some time to introduce myself, but I wanted to introduce myself as well. As you mentioned, my clinical specialty is working with those with suicidality and self-harm through different practice settings, primarily through DBT, which is my specialty. But I've been in the suicide world for quite some time. I started working with suicide when I was 16 in a peer model. I struggled with my own suicidal thoughts and desires for a lot of my late teens and early 20s, and found a lot of meaning in supporting others who were going through similar crises, joining a peer crisis support line when I was 16, and staying in crisis work for quite some time before I ended up coming back into the social work field. This is something that I'm really passionate about, and having worked quite a bit with a lot of folks who experience suicidality and suicidal struggles, one thing that we often see is the way that we approach suicide as a field and the way that people who are suicidal want services. And what the research shows is effective for folks who have suicidal thoughts and behaviors. There can often be gaps between those two and three different areas. So I'm really excited to dive in and talk about how we as a community can better support those with suicidal desire. As Philip mentioned, suicide is often a very emotionally charged topic for a lot of people. At the beginning of this presentation, we're going to talk about some of the prevalence in the US and specifically here in Utah around suicide. But the reality is that we know many people are very deeply and personally impacted by suicide. So given that this presentation is going to be covering this topic, I really encourage you to be mindful of what shows up for you and allow yourself to practice some compassion and care for whatever needs show up for you as we go through this presentation. Lastly, I also just wanted to make a note that as we go through this presentation, we're going to be talking about some of the ethical considerations around navigating care for suicidal people. And I want to be mindful that I'm not a lawyer, so I don't want to put myself in the position of answering any sort of legal questions or challenges here. But my hope is that we'll be able to come together and talk through some ethical considerations that we can apply as we navigate the other considerations in our practice. I will plan to answer questions at the end, so feel free to share those in the chat. And without further ado, let's dive in. So to start off with, I just wanted to share the state of suicide prevalence here in the US. We know that this is something that, especially through the 2010s, we saw a significant and continuous increase, and we've seen that plateau to some degree in the last few years, but we're not seeing any return to some of the previous levels of suicide risk that we've seen prior to that rise. We know that in 2022, about 5% of adults reported having serious thoughts of suicide, and about 0.6% of folks in the US, broadly speaking, made suicide attempts, made attempts to die in that year. And so we know that this is an incredibly prevalent issue in our community. And we know that with clinicians, regardless of your specialty, studies have shown that a large majority of clinicians will encounter a suicidal person at some point in their career. The statistics range in the upper 90%. So even if this is not your specialty, chances are you have or will work with someone who is suicidal. Specifically in Utah, we are often higher than the national average for suicide death. And so when we're talking about the prevalence here in Utah, we see a suicide death rate of 22.1, and we had 696 suicide deaths reported here in Utah in 2023. Looking at this map here on the right-hand side, this is from the CDC exploring suicide rates across the country. We see that Utah is seated in what we often refer to as the suicide belt, this Mountain West region and rural region in Central West America that often has much higher suicide rates than any other part of the nation. And this has been fairly consistent for the last 10-ish years. And so we know that Utah is in the center of an area of the country that often really struggles with suicidal behavior and has a higher suicide risk. And we also know that when we look at the practices of people here in Utah, that there's a lot of folks within Utah that are providing rural and telehealth services to a lot of these primarily rural regions that have high risk of suicide. And so if we know that across the country, upwards of 95 to 97% of clinicians will work with someone with suicide, we know that in Utah, that's likely even higher. And so it's so important that we have the tools to be able to understand how to navigate suicide in an effective way and an ethical way. To bring in some more specific populations here, we know that youth are also at high risk for suicide attempts. 9% of Utah high school students attempted suicide in the past 12 months from a 2023 survey. And we also know there are certain populations that are here that can also be heavily impacted by suicide prevalence rates. Particularly, we know Indigenous communities, often referred to as Alaska Native and American Indigenous communities or American Indian communities, have a much higher prevalence of suicide rates and suicide deaths. We also know that white men in rural areas in particular have much higher rates, which is something increasingly common here in the Mountain West, the rural community growth. And we also see that the age of suicide risk has shifted over time. So a lot of times, especially even when I was in grad school, we talked about how older adults tended to be the highest risk. But we've seen over the last decade or so that shift to middle-aged adults and even young adults. So the highest risk group now is between ages of 25 to 44. And we also know that LGBTQ communities have high suicide risk as well, particularly gay and trans members of the LGBTQ community. And recent research has shown that we're seeing a higher increase in risk for people of color, particularly Black youth is something that the research is indicating much higher risk with suicide in the last several years. So to understand all of this helps us recognize that suicide is all over, especially here in Utah. There are people who are navigating their challenges with suicidal desire, and we have certain communities are more likely to be impacted by others. But at the end of the day, we all are likely to come into contact with suicidal people in our clinical work. So it's really important that we understand how to do that effectively. Now, that's not always easy, though. One of the things that we know when it comes to suicide is that this is a highly stigmatized experience. We know that there are many societal norms and perspectives on how we view suicide. There's moral perspectives on suicide as a moral failure, religious or spiritual perspectives on suicide as sin or an affront to certain religious beliefs. We know that there's ideas or perspectives on how we need to better just pull ourselves out of depression or sadness, or how even just the desire to die is irrational or illogical. And all these societal perspectives and norms shape our own beliefs as providers. When I'm training providers on suicide, we often talk about this tension between preserving life and recognizing someone's autonomy. And our perspectives and our societal influences on how we see suicide and suicidal behavior perpetuates different stigmas and ideas on where we need to be as providers on this spectrum, how we balance autonomy and preserving life, and what is ethical to do so. There's so much gray in this field, particularly around what we need to do in order to protect life while also holding our social work values of honoring the dignity and worth of a person and their autonomy. Specifically with suicide, we know that because of the risk of suicide and how it feels to interact with systems having suicidal desires, we know that people with suicidal thoughts and behaviors are less likely to participate in research. They're less likely to participate in mental health services. And even when they do, they're less likely to be open about that, which makes it harder for us to understand the lived experience and what community of people with suicidal desire wants and needs from their mental health services. We also know that even within the professional field, it can also be challenging for people who have lived experience to share that as professionals, to share as a social worker. I've had suicidal thoughts. I've attempted suicide before. To say that and engage in research or clinical work can often feel quite stigmatizing, which can make it really challenging for people to bring that lived experience and that wisdom to their practice and to research. And we also recognize that because suicide, different than many other mental health conditions and struggles, is highly lethal and prevalent, we know that a lot of people die by suicide. And as a result, there's a loss of wisdom. We don't have the ability to study and understand the needs of people who have already died by suicide. And so this is a really challenging area for us to try to synthesize this inherent value, not only in what the research says and what our practice protocols and wisdom says, but also the wisdom of those who have lived experience. And so as we go into this presentation, my hope is that we can try to approach that, try to blend these ideas together and understand the disparities that exist in the social work and mental health field between lived experience, research, and intervention. And particularly, we'll be focusing on three core areas that these gaps are often widest, which is how we navigate the disclosure and assessment of suicidal desire, how we navigate the ethical quandaries of confidentiality and autonomy with suicidal people, and what levels of care and interventions are effective for people who have suicidal thoughts and behaviors. And so we're going to dive into the disclosure aspect of suicide. So when working with suicidal people, one of the things that's really helpful to know right off the bat is that even though suicidal people or people with suicidal thoughts and behaviors are more likely to disclose their suicidal desire to a therapist or a clinician than they are to their friends, family members, partners, or health professionals, still only roughly 50% of people do. And so what that means is for every suicidal person that you've had on your caseload, there's a chance that you've had one other person who is suicidal who did not share their suicide risk with you. And this is really important for us to be aware of. It's also helpful to be aware that within that non-disclosure prevalence, we see there are certain groups that have higher risk of non-disclosure, particularly for men who are age 70 plus. We know people have less social connectedness, so report having fewer relationships, and people of color are less likely to disclose their suicidal desire. And hopefully we'll be able to put some context to that as we talk about the lived experience of disclosing suicidal thoughts and behaviors in just a moment. There are also factors that are protective when it comes to suicidal desire. We know that the younger you are, the more likely you are to be willing to disclose. We know that higher levels of education are correlated with higher levels of disclosure. And we know that people who have more severe ideation or have higher attempt rates in their past also tend to have higher disclosure rates. Now, some of the research indicates that is because it's harder to hide or conceal, meaning involuntary or non-consensual contact with assessment or experiences with mental health care systems. But we also see that that desire to get help with higher risk of suicide can drive people to being more willing to disclose suicidal desire. I mentioned earlier that younger adults do have higher levels of disclosure, but when we're looking at youth, in particular youth of color and cisgender youth, we know that they are less likely to disclose, and those groups in particular, compared to other youth, are 1.5 times less likely to disclose suicidal thoughts and behaviors. So we see again disparities within suicidal disclosure that youth of color and cisgender youth are less likely to disclose than white youth and gender or genderqueer youth. And so why does this happen? What are the lived experiences that help us understand this data? So we know that one of the things that often shows up for people's lived experiences, they report had they been asked more directly about their suicidal thoughts and behaviors, they would have been more likely to provide information about their suicidal risk. One common trend in both the quantitative and qualitative research around lived experience, and including in my own practice experience, is that when clinicians are beating around the bush, so to speak, or tiptoeing around the subject of suicide in their assessment, it can often feel quite uncomfortable for the person on the receiving end of that assessment to feel like they're able to share about their experiences without stigma, or to know that the person that they're talking about is someone that is willing to talk about and hold space for the suicidal behaviors or suicidal desires. And so when we survey people with lived experience of suicidal desire, we know that that direct assessment is so crucial, and indirect or lack of assessment often encourages people to want to hide their suicidal desire. And in addition to that, with the qualitative data, we know that people with suicidal desire are less likely to disclose for a handful of reasons. One of the biggest ones that shows up is fear of involuntary hospitalization. We know that there's a norm in this field around viewing suicide as something that needs to be intervened with a higher level of care that often involves hospitalization. And in some ways, that can be effective in certain instances, which we'll take today as well. And it can also be a huge risk factor, particularly when looking at the lived experiences. We see people often endorse a fear of, I don't want to lose my autonomy or my freedom. Going to a hospital for suicidal risk leads to a complete loss of autonomy in a lot of ways, not only inability to move about and live your life, but inability to control who you see, who you talk to, what coping skills you have access to, what support systems you have access to. And so it can be a huge risk factor for people in disclosing suicide, especially if they're not sure what will happen in that disclosure. Will I be hospitalized? And we also have to recognize that there's a huge risk of financial hardship as well that comes from hospitalization. The ideal is that people who are involuntarily hospitalized don't have to pay for their services because they're there against their will. But we know that's not how our mental health care system works. People are often faced with hundreds, if not thousands of dollars of bills when it comes to emergency hospitalization for suicidal risk. And that financial hardship, we know, is also a huge risk factor for increased suicide risk as well. And so the idea of disclosing suicidal desire to a clinician and facing involuntary hospitalization can lead to people deciding to keep that risk to themselves and keep that desire to themselves. We also know stigma is a huge factor. Stigma is a common belief around why it's not helpful to disclose suicidal risk, worrying that people have stigma towards suicidal beliefs and desires. And it's incredibly common for people to experience stigma when navigating mental health care systems with suicidal desires. Medication risk is also a big fear. If I disclose my suicidal desire, will I be required to take medications, change my medications? take higher doses of my medications in a way that I'm not sure I'm willing to do or not sure that I'm willing to face because it has these side effects or these impacts on my life, or I'm not someone who wants to take medication for whatever reason. And there's also the impacts on support systems, worries that if I share my suicidal desire with my social worker or my clinician, will I be rejected? Will I be referred out and said, hey, I don't work with suicidal people. You need to go find someone else. I talk to my friends and my family members or my healthcare provider, or if I tell my therapist or my clinician or social worker, will they then tell other people? And now I have to face the fear of rejection with my support system, with my parents, with my partner, with my loved ones. And so all these fears come up quite often in the research around why people don't disclose. And given that that's half of people, these are really important for us to be aware of. And specifically when it comes to adolescence, we know that parents are a huge barrier. So even when we do that a suggested task of asking directly, are you suicidal? Let's assess your suicide risk explicitly. Adolescents, even in those instances, 25% of adolescents still did not disclose their suicide risk behaviors because of fear, specifically of that ending up with their parents and their parents reacting in a way that they find unhelpful or they're not ready for them to know about that risk. And so, on the flip side, looking at provider perspectives on assessment, we know that providers also struggle with this. Providers struggle with being uncertain about the correct way to ask about suicide, worrying about should I ask about suicide, and not asking about suicide at all, maybe asking in an initial contact, but not asking in follow up contacts, not asking directly. There's a myth that often shows up for people if I ask about suicide, will it give my client ideas about suicide? And we know that this myth has been disproven. So it's really important that if you're holding on to that today, you're not alone. And it's something that I invite you to throw out the window because we know that the research shows talking about suicide with clients does not give them ideas about suicide or increase suicide risk. In fact, the research shows talking openly and directly about suicide decreases suicide risk and increases willingness and openness to talk about suicide risk. We also know from the research that providers are often focused on liability management, which is not a bad thing, definitely something we want to be considering. And if our assessment is focused on liability management, we see from the data that providers tend to focus on identifying very specific risk factors rather than having a more holistic understanding of suicide risk and engaging in suicide conversations collaboratively. So, what do we do with all of this based off of this lived experience from both clinicians and people with suicidal thoughts and behaviors? My takeaways from my own practice experience is that one thing that is key is that we ask about suicide with every single client that we come in contact with. We know from the research that most people who die by suicide have had recent contact with a health provider or mental health provider. And so, if we are not asking about suicide, then we are failing our clients. And if we know that asking about suicide directly increases the likelihood of a client disclosing it, it's imperative that we do so. Now, of course, this can be nerve wracking. Of course, this can be scary, and we maybe aren't sure how to do it or what the right words are. And what the research shows is it doesn't really matter as long as we go in with full openness to what shows up. There's no right words. There's certainly tools and strategies we can talk about that are helpful, but demonstrating that we are open to the conversation, that we are willing to talk about it explicitly and directly, and doing so rather than tiptoeing around it or deciding not to at all is the key here to be able to assess those risk factors. Now, in addition to this, it's really important that we also assess their experience with their suicidal behaviors. We know for people who have had a breach in confidentiality in the past, or involuntary treatment in the past, or have had a negative experience when disclosing suicidal risk with someone, they're less likely to disclose. And so we want to assess those risk factors themselves, not only the general suicide risk factors, but also what has your experience been like in the past when you've shared your suicidal thoughts and desires with friends, family members, peers, coworkers, colleagues, mental health professionals, healthcare providers. And how can our understanding of those past experiences help us tailor how we assess suicide risk as providers in that therapeutic relationship? In addition, because we know that there's different cultural considerations and factors that influence whether people disclose and how people disclose, we want to make sure that we're tailoring our assessment to specific cultural considerations. We want to be mindful of what language our clients use, recognizing different cultural experiences or lived experiences, use different language for words around suicide or suicide risk or the desire to die. We want to know about how that suicide risk might be reacted to within their community, within their beliefs, within their values, both individual and community values. And there's tools to help support you in this as well if this is something that you don't have as much training in. It's a pretty quick presentation, so we won't be able to get into as much depth with this specifically, but one place I recommend folks start is to explore a tool called the Cultural Assessment of Risk for Suicide, which is an assessment tool that's freely available online and evidence-based. We also know that it's so important that we provide suicide resources, psychoeducation, and normalization of suicidal desire, even if that person says, I'm not suicidal, I'm not in any desire to die. We still want to take, even if it's just a minute or two of our time to recognize and say, hey, great, love to hear that. That's totally fine. And if that changes, here's places that you can go. Back to me, use these crisis resources, use these educational resources. We know that suicide is highly prevalent. We know that people struggle to talk about suicide, and many people still won't share about their suicidal desire, even when asked directly. And that's totally normal and fine for all these reasons. Because what that does is it opens the door for a client to then bring up suicide down the road. Or if they're part of that 50% that won't disclose suicide to the provider, we know that we're doing our due diligence to help them recognize that they still have resources and that it makes sense for them to feel that way and that they have options if and when they're ready to talk about it or to get support, whether it be with you or other people in their life. And lastly, we're going to talk about this a little bit more later on, but it's important to provide assessment and doing so with clear, informed consent prior to engaging in that. So we want to make sure that if a primary concern of clients in disclosing suicide risk is, I'm going to be hospitalized involuntarily, or you're going to tell people in my life, we want to make sure we're addressing that right off the bat before we even start to ask questions. We want to be very clear on what would happen if you disclosed certain kinds of suicidal desire, suicidal behavior, suicidal thoughts, suicidal actions, intent, and planning. I'm going to get really clear so our clients know what to expect. I'm going to talk about some different considerations for that later on in this presentation, but I also recognize that some of you might be in contexts where you don't really have the option to choose how your agency responds to suicide risk. You might have protocols, policies that you're having to navigate, and it's really important that even if you don't agree with those, or even if you don't know that it's going to help your client openly talk about suicide with you, that they're aware of that so that way they can navigate and make choices and honor their autonomy as a provider. So as we move into the lived experiences when it comes to confidentiality and autonomy, so once disclosure has occurred, what do people experience? In a 2022 study of adolescents with suicidal ideations and behaviors that reported at least one experience in which a mental health provider either forced them to tell a parent or guardian about their suicidal ideation, thoughts, or behaviors, or told a parent or guardian without their permission. And so we know that for adolescents in particular, this risk of a breach of confidentiality is very real. So that's about 1 in 2 adolescents who are suicidal will have an experience in which their confidentiality was breached. And we know that once confidentiality is breached, they are less likely to report future suicide risk. So that same research study showed that for these teens who experienced a suicide breach or suicide confidentiality breach, they reported negative impacts on the therapeutic relationship. They reported decreased trust in mental health services more broadly. They reported decreased willingness to disclose any sort of future suicidal thoughts or behaviors. And it also impacted their mental health. So once that breach occurred, those teens were more likely to experience in higher depressive symptom intensity, increased suicidal urges, and decreased self-worth. And one of the things that this study also highlighted that I think is so important is that with the same sample of teenagers for teens who had collaborative breaches. So that means that when it was disclosed, their provider, their social worker, their therapist worked with them to talk about how can we make sure that the people who need to know this together? How can we collaborate on what it will look like to share this information with other people? Teens who went through that experience had positive impacts on all these factors: improvement on their perspectives of a therapeutic relationship, trust in mental health services, increased willingness to disclose in the future, and a decrease in these mental health symptoms. So when we're talking about that breach of confidentiality, we know the collaborative nature on it. It's hugely impactful. We also know that more broadly speaking, moving beyond teens, that survivors of suicide attempts indicated that some of the most common negative factors influencing their perception of care included loss of autonomy, including hospitalization and medication management, as well as breach of confidentiality. And so, to put some context to this, the Fox article that I'm referencing here, there's a quote from this that I really love, which is from a client that really speaks to how it feels to navigate mental health systems with suicidal desire. The client said there that fear of losing autonomy always guides what or how much I disclose to a mental health provider, family, and even friends. Frankly, it really sucks to have to deal with mental illness that already makes me feel alone and trapped. And on top of that, having to navigate how I go about asking for help and fear of being further isolated and trapped. My fear of hospitalization comes from traumatic involuntary experiences and the knowledge that, at least where I live, there's a giant gap between what is needed and what exists affordably and accessibly. And this quote really speaks to the increased distress that comes from already having suicidal desire and then having to navigate these mental health care systems with uncertainty of how they'll respond, and this recognition that there are massive gaps in the services that we have available to suicidal people. And what that means is these people are having to navigate those gaps while also navigating what might happen if there's a breach in confidentiality. I've had my own clients who've been suicidal tell me throughout treatment, maybe after months of not disclosing suicidal thoughts, that they didn't tell me because they were worried I was going to hospitalize them, even though I have a very explicit and clear informed consent process that I go through with my clients. Clients are still really fearful of that. This client in particular had been hospitalized against their desire multiple times with previous providers, so it makes sense. I've also had clients tell me that past therapists have told parents they're suicidal and dramatized it and told them that they were more suicidal than they actually were, or and that staff believed their parents versus them leading to hospitalization that wasn't actually clinically effective. And I've had a lot of clients tell me in our first intake session how grateful they are that I've taken the time to really spell out what is confidential between us and what isn't when it comes to suicidal risk. And that is so impactful and so important to hear as a provider to help us know that we're doing something right because it helps our clients be open and honest with us. And so when talking about this, I think it's really also important to understand the data around what happens with confidentiality and autonomy. One of the things that a lot of providers don't know is that involuntary hospitalization is actually a huge risk factor for suicide death. Involuntary hospitalization is associated with greater hopelessness, loss of autonomy, loss of connection, and increased risk for suicide attempts. We know that history of breaches in confidentiality decrease likelihood of disclosing in the future. And specifically with hospitalization that's involuntary, one of the riskiest times for someone to die by suicide is post discharge from hospitalization due to suicide risk. And so this is something that's really important for us to consider. I'm not saying that hospitalization is bad or shouldn't be used in any way, but if we're focused on our liability or focused on keeping someone alive and viewing involuntary hospitalization as a necessity, we also have to make sure that we're balancing in that equation or that calculus of ethical decision making, that we're also increasing our clients' risk of suicide death by doing so. We also know that hospitalization is associated with post-traumatic stress. We've seen studies that people post-discharge from involuntary commitment have higher elevated levels of post-traumatic stress afterwards. We know that there is a felt loss of connection, increased hopelessness, financial hardship, and generally speaking, poor mental health outcomes for those that are hospitalized versus those who are not. And so when we look at what this lived experience and this data shows us about confidentiality and autonomy, there's some things that are really important to consider in how we approach our clinical work. The first is, like I mentioned, being really clear about informed consent for confidentiality breach. So we want to know and make sure our clients know exactly what would happen if they disclose suicidal behaviors. For me, my spiel that I give clients is I tell them that suicide is something that we will and should talk about, and I really want them to feel comfortable talking with me about, and it will stay confidential between you and I. This is an adult client for the sake of this explanation, but there's some tweaks I make for teens. But everything will stay between you and I, except for if 5 criteria are met. One, you're having suicidal desire. 2, you are planning to do something to make an attempt on your life. 3, that attempt is feasible, you have access to it, and it is lethal. 4, you are planning to do so in the very near future, so between now and when you and I next meet. And 5, you have zero interest in safety planning or figuring out a way out of it. If all 5 of those criteria are met, I may be required to do something to protect your life, do my due diligence and my legal due diligence. But if they're not, then it's going to stay confidential between you and I. And even if we get all 5 of those met, I still would much rather do it in a collaborative nature. And so when discussing hospitalization, I think it's really important for clients to know all of that before they even disclose, because chances are they might not want to disclose that with you if they don't know the parameters. And I'll often encourage clients to recognize that's a lot to remember. I sometimes have a hard time remembering my spiel, so feel free to ask in the future. Feel free to check in and remind yourself, what are the parameters of confidentiality? And so if we are talking about this, it's also important that if hospitalization or involuntary commitment or breach of confidentiality shows up, that we plan accordingly if involuntary hospitalization or hospitalization is utilized, given the risk that shows up from it. So in discussing hospitalization, it's really important that we recognize that in hospital admittance, there may be stigma or response from providers that feels stigmatizing or invalidating or painful. A majority of people who interact with emergency department staff are likely to experience a stigmatized response. That's what the data shows. We also want to orient clients to expectations of a hospitalization, recognizing that within hospitalization, oftentimes people hope that hospitalization will cure them, will fix them as a necessary intervention. And what the research shows is that hospitalization actually doesn't improve mental health. It can be a helpful way to get emergent medication management or triaging. It can be a helpful stopgap for care when we don't have the tools or resources available to keep someone safe. And it's not going to decrease suicide risk or decrease mental health concerns. In fact, oftentimes it exacerbates it or has a neutral effect at best. And so we want to orient clients to the function of hospitalization and make sure that they're going into it with expectations of what might happen while they're there, what services they'll receive, and what will happen post-discharge, which we also want to plan for and make sure that our client has meaningful and substantial immediate contact and support post-discharge because of the increased risk at that point. We want to explore financial and insurance considerations, considering that financial hardship is also a huge risk factor. So understanding, do you know how much this will cost you? Do you know how much your insurance will cover? Are there certain hospitals that are going to be better for you financially or insurance-wise than others? And how can we make sure with all of this that there's a support system that you have available to you before you get hospitalized, during the hospital stay, and post-hospitalization? The second thing to consider here when it comes to our practice considerations is that we want to consider that maintaining confidentiality is an evidence-based and ethical consideration. Sometimes we can feel like there's a need, I have to disclose this to someone to avoid liability, or I feel like legally I'm supposed to. And there's a lot more gray than clinicians often recognize because we have the ability to make an ethical decision-making process with suicidal clients. We can weigh the risks of breaching confidentiality with the risks of not, and do so in a very intentional, evidence-based way based off of the research that I've shared with you today. Especially for clients who don't have imminent risk, it's so important that we recognize that if at all possible, we want to try to do this in a collaborative way. And if we have the time to do so, going to be the most effective path forward is recognizing that there may be some interim risk that we have to sit with and experience discomfort around because breaching it to get rid of our discomfort as providers is likely going to increase risk for our clients. So we want to make sure that we're utilizing our clinical tools and taking the time that we need to explore the possibility of a collaborative breach of confidentiality or change in level of care rather than jumping to breaching that or changing level of care without consent. And there's different clinical tools that can help. I love DBT because they have a lot of really meaningful therapeutic and relational strategies that can help have these hard conversations. I think motivational interviewing is also a really helpful tool. And there's other interventions that we'll talk about later today in just a moment as well to help understand what tools you can add to your toolkit to better support you in these conversations. So when talking about this, the other thing that we want to recognize is that there's different lived experiences around different suicide preventions. I'm going to go through some of these fairly quickly just to make sure we have time for Q&A. But one thing that's important to recognize is that when it comes to emergent or crisis services, 41% of people with suicide thoughts or behaviors found utilizing emergency departments harmful or unhelpful at best. So while that's not a majority, it's still a very significant portion of people, which means that we're finding that experiences of emergency departments can be quite painful and harmful for people with suicidal thoughts. Additionally, to add some more characteristics to that, we recognize that 60% of people, over 60% of people seeking support for suicidal thoughts and behaviors in emergency departments reported feeling stigmatized by providers, which speaks to why maybe many find it quite harmful or unhelpful. And we also know that only about a third of people with suicidal thoughts and co-occurring mood disorders, this was a more specific study, but we don't have a ton of data, so we're working with what we got here. But we know that only about a third of people will use crisis hotlines when they have suicidal thoughts and co-occurring mood disorders, which is a relatively low amount. And so we know that emergent services are often seen as unhelpful or harmful and are less likely to be utilized than other services. We also know that family intervention can bring up quite a bit of tension for folks with suicide risk. For those with suicide risk, family support is often seen just as harmful or unhelpful as emergency services. And we also know that families report intervention or being included in intervention around suicide risk also feeling quite challenging. Families have reported feeling unclear of like, what am I supposed to do in my role as a family member? Struggling with hypervigilance about suicide risk when incorporated into family intervention planning, and feeling like a lack of collaboration in discharge with healthcare providers. So we know that both family members and the suicidal individuals themselves often have unhelpful experiences with emergency services. We also know that that stigmatizing that happens for people who are suicidal in emergent settings also happens for family members to a lesser degree, but nearly a third of family members of a suicidal person felt stigmatized by healthcare staff. On the flip side of this, though, we also know that people with suicide risk see family members as a protective factor in reducing risk or future attempts. So while that family support or family participation in intervention can have mixed results, we know that that family relationship can be a huge source of resiliency. And we also know that one of the most impactful interventions for decreasing the risk of death by suicide is removal of access to means. Family and social support can be a crucial aspect of that access to means counseling. So that can be a way that we can greatly reduce suicide risk by engaging with family or social supports. Now, I also like to talk about peer supports because as evidenced by this slide, we don't have a ton of data on peer supports. But the data that we do have shows us that peer support is used by a minority of people with suicidal thoughts and behaviors, but is often seen as a highly useful intervention for those who are able to utilize it and a really desired resource by those who don't have access to it. And I started my career in suicide as a peer support provider as a teenager at the time, which sometimes is wild for me to think about that they let me do that. But The idea that we have someone who knows our lived experience and understands suicidal desire and suicidal behaviors is such a huge protective factor and such a source of strength and resiliency. Now, sometimes when we talk about this, folks get nervous, especially when we think about contagion, especially with adolescent contagion, this worry of how kind of collaborating and talking about suicide risk together can often increase risk when it's done in a way that um, is supportive of suicidal behavior, is supportive or glorifying of risk factors. What we're talking about here is not so much that, and more so about this idea of structured peer support services and including people with lived experience in care teams for people who are suicidal, including resources, peer support services for folks who are suicidal. Now, when we talk about mental health services more generally speaking, there's associated with positive experiences of having suicidal thoughts and behaviors in mental health services include collaboration, particularly in the treatment planning process, increased social support, supportive medication management, so collaborative medication management, having trustworthy providers. And this next part that I like to really highlight is also being appropriately challenged. One of the misconceptions that often shows up in working with suicidal people is that they're fragile. We say the wrong thing, make a joke, do something that challenges them, that we're going to push them over the edge and they're going to die and it's going to be our fault. What we actually see from lived experiences in mental health services is that people with suicidal thoughts and behaviors actually find being challenged really effective and really helpful. Again, to really talk about DBT here and give it its dues is that DBT uniquely really incorporates in a manualized way what we call irreverence, this idea of doing things that might catch our client off guard or help them get unstuck by saying something perhaps unexpected or even outlandish. And we see that that's actually really effective for people who are stuck in very rigid beliefs or ideas about what is happening or what is available for them or what hope they have access to. And so my hope is that people see this and recognize that suicidal people are actually very resilient, right? The ability to stay alive and have this desire to die while continuing to go through your day to day is not easy. And so we have to be able to hold space for the fact that we can treat suicidal people with care and compassion while still allowing that relationship to be genuine and appropriately challenging. And similarly, one of the highest indicators of positive experiences with social services is the ability to talk openly about suicidal desire with empathy and lack of stigma. The ability to say, I'm suicidal, here's what it feels like, here's what it looks like, here's how I'm thinking about it. And to be able to talk about that and see that there's something about this that makes sense. There's some function to this that makes sense for you. And can we hold space for that rather than say, you shouldn't be feeling this way, or this doesn't make sense, or it's irrational? Holding that dialectic here of both that you can feel suicidal and it can make a lot of sense while also recognizing it's maybe not the most effective option for you. Being able to hold both of those for clients can be so crucial for having positive experiences. When it comes to negative experiences, we know some of the biggest things that show up here is inadequate assessment. So clinicians often, sometimes maybe even guided by liability management versus thorough assessment, or hearing suicide and jumping right into action. Clients really want to be able to feel heard and really understood when it comes to their suicidal risk rather than having their risk dramatized or minimized or just touched on and then moved on from. We, of course, want to show up with less stigma. We also want to make sure that if you're on a team that is using medication management or you're a medication manager yourself, that we prescribe with really thorough assessment. Sometimes people with higher emotional distress or higher levels of suicide risk will often be overprescribed in a way that can be quite harmful and lead to not wanting to participate in mental health services anymore. We also want to make sure that we're not acting uncomfortable around suicide desire or attempts. Of course, it can be uncomfortable as providers or scary as providers to hold space for someone who is feeling suicidal. And we want to make sure that we are not responding to that in a way that is punishing by saying, I feel uncomfortable with your distress. Imagine how they're feeling if you're just having to hear it. We want to make sure that we really try our best to manage our own reaction to the disclosure and hold space for that pain rather than bring our own discomfort into the equation. And of course, people have also emphasized that there's inadequate referrals or level of care options, which we know is an unfortunate reality of many communities, including here in Utah. Middle levels of intervention between outpatient and hospitalization are not super available. And the ones that exist can vary in approach and in quality and length and duration and intensity and access when it comes to financial capabilities as well. And so we recognize that middle level of care is significantly lacking, and people with lived experience recognize that and see that. Okay, I'm almost to the end here, and then we're going to take questions. It's important to highlight that 82% of people who have attempted suicide have endorsed at least one negative experience with mental health services. So we know that people navigating these systems have negative experiences, whereas only 14% had only positive experiences. So I touched on a lot of this already, but it's really important to recognize that we can normalize and validate suicidal desire. Oftentimes, that suicidal desire is a way to have the idea of escape from pain and suffering. And so we can recognize that that makes sense. All of us don't want to sit in pain and experience the hardest parts of our life. And so it's really important that we normalize and validate that desire. We talk about it openly, and we make sure that we're utilizing ethical decision making to inform our assessment, our intervention, and referrals, making that assessment open, conversational, and collaborative. And recognize that if navigating or moving towards higher levels of care or referring out is often where harm is increased or risk increases, can we invite in more non-traditional interventions for social support and safety planning? Are there other places that this person can go besides a hospital that will help them stay safe? Are there people they can be around, places they can hang out in? I often like to joke that a Denny's is a great place to hang out because it's open 24 hours and there's always people there. That might be a whole lot cheaper than a hospital stay. And if our client is willing to explore ways to have that be part of their safety plan, it's important that we do so when we recognize the risks of other interventions like navigating to a higher level of care like hospitalization. And so one other thing I like to mention too when talking about assessment is just that risk is something that we cannot guarantee. There's a bunch of research on understanding imminent risk for suicide. And the conclusion of all that research is that it's mildly correlated at best when it comes to understanding who is likely to make a suicide attempt in the imminent future. We simply don't have the ability to predict that. So I think it can be important for us as clinicians to hold that balance of I won't be able to know for sure what's going to happen with my client. And I'm making decisions based off of the research and ethical decision making rather than trying to control something that unfortunately we cannot control. That doesn't mean we need to give up on trying to keep people safe, but it means we need to recognize that the fear that often overtakes us as clinicians and skews our ethical decision making is powerful and something that we can't ever truly make go away. And so, what we can do instead is provide evidence based intervention. And so, this is my last couple slides. I'm about to get ready for questions. I have included this slide just because I think it's helpful to know what evidence based interventions are out there when it comes to assessment, safety planning, and intervention. Um, I believe that we'll be able to share these slides, but if not, hopefully we'll talk about how you can get these. But this is a list of interventions. There's a few open assessment protocols out there. The most common one is the CSSRS, which many people are familiar with. Safety planning, I highly encourage looking into collaborative assessment and management of suicide, and the safety planning intervention, which can be really effective when done with intention. And different treatments that work for suicide are brief CBT, what's called CAMS or Collaborative Assessment and Management of Suicide, cognitive therapy for suicide prevention, and DBT. Lastly, liability management. I mentioned this earlier. Ethical and evidence-based practice is liability management. If you are making your decisions based off of the research, what data shows is going to be effective and ineffective, and you are documenting that, consulting around that, and demonstrating your competency and understanding of that, you are managing your liability. And so it's really important to keep that in mind. And doing all of this with informed consent, making sure that our clients know the evidence base for treatments we're providing, how we're going to hold confidentiality, what to expect in treatment, how we're going to navigate contact with other providers, and how we'll engage other contacts or safety planning when risk shows up. Okay, let's jump into questions. I know I was a little bit rushed at the end, but I really wanted to make sure we have some time for questions here. Okay, the first question I see here is on the statistic of 50% of people only share their suicidal thoughts with a counselor. Does this mean that clients may be dishonest even if asked directly? Yes. So the statistic actually rises when clients are asked, when included clients that are asked directly in that specific subset. If you ask your clients directly, they're much more likely to disclose. However, there still will be a subset of people that will not disclose their suicide risk, even if we ask them directly. And so we always want to make sure that we're asking them directly and recognizing that even that we still might not get all the data that we want, which is why I think it's so important for even people who deny any sort of suicide risk that we still provide them with a brief understanding of resources, information, and normalization of suicide, how common it is, and how it's sometimes difficult to talk about in treatment. And for people who deny suicide risk but have suicide risk factors, I will usually encourage clinicians and do this myself, where I'll still check in semi-regularly, if not within each contact on suicide risk, depending on their level of risk factor. Jerry asked, can you share your informed consent document with us? I'm happy to do so, and I don't know the logistics of how we're going to send or if we can send things out, so we might have to follow up on that one. All right, someone asked, can you repeat the criteria of parameters for confidentiality? So my parameters are want to die by suicide, have a plan on how to do so. The plan is feasible, so they have access to it, and it is an actually lethal plan. They are planning to do so in the very near future. So I usually say imminent is within the next couple days or between now and our next contact, depending on what intervention I'm using with them, because with DBT, we'll have contact in between sessions. And then the last one is they have no interest in safety planning or finding ways to stay safe and reduce their risk. Those are the parameters in which I'm going to, if I'm not meeting 5 of those criteria. Okay, the next question is, I find that being a hospital social worker that values letting people have a choice in how they lead this life as much as possible. I'm not sure if I'm faced with someone with suicidal ideation that I would do much to report it or try to talk them out of it. Could I be held liable for not reporting SI to someone? I might not be the best person to answer this question because I don't want to speak in legal terms confidently since I'm not a lawyer. I will say there is legal precedence that we do have the duty to make sure that we protect someone from imminent risk. And imminent risk is not clearly defined in any state statutes, including Utah's state statutes. Again, asterisk, I'm not a lawyer. So there's ethical gray there, which I think is what makes this challenging. But if there is imminent risk and severe risk to someone that could happen in the near future, I believe a lawyer would likely say we still have the liability if we don't report that, but not a lawyer. And maybe Philip's about to cut me off and say, stop giving legal advice.
That wasn't what I was going to say, Josh.
Okay,
It was that
okay.
we're out of town.
A bummer.
Unfortunately. Yeah, but what I did ask Janae to do is to write down all the questions that were in the Q&A, and then we'll ask if you can provide some short responses to those, and then we can make them available to the attendees, if you're okay with that.
Perfect. Yeah, absolutely. Have you noticed any positive or negative change with the implementation of SafeUT and mobile crisis team? I will say personally, I haven't noticed anything specifically around the changes with SafeUT and mobile crisis team. As I mentioned earlier, I think a lot of folks are quite hesitant to use emergent services as part of their response to their own suicidal risk. Thus, I'm less likely to see someone really find value in those services. And I often find those to be helpful points of contact for people who have limited social support. The SafeUT app has also been a helpful tool for identifying adolescents or peers who are concerned about their fellow students or friends who are having concerns. In some ways, I've found that helpful to alert folks to those issues. In other ways, I've had clients find them less helpful, especially recognizing that mobile crisis outreach teams can have different team compositions, will sometimes engage in outreach with other providers as well. That can sometimes changes people's experiences of those services. So it's hard to say kind of broad strokes what I've seen with that. Um, but those are some of the things that I've noticed. Question is asked, which is what is the tweak to your disclosure speech that you use for adolescents? So with adolescents, I'll actually have a conversation with the teen and the parent or parents in the room together, where I'll talk about how legally speaking, parents have access to their child's medical records, and thus confidentiality is something that I can't legally maintain. And when I work with teens, I have both the teen and their parent make an agreement that the parent will not seek or request their medical records, request information about what's being talked about in session, because we know that confidentiality is a really important aspect of people being able to talk about suicide risk. And I'll tell parents, if you want your teen to get help with any sort of suicide or self-harming risk, they're going to need to be able to talk about it. And if we don't have confidentiality, the research shows that they're not going to talk about it with me, whether we want them to or not. So my ask is that you hold that confidentiality as if they're an adult. And I'll make the agreement that if your teen is engaging in any high risk behaviors that are putting their life or at risk or putting them in serious medical risk or injury harm, then we are going to have a conversation about how to bring parents in on that. But up until it reaches that point of imminent risk or serious harm, then parents will not be involved in that conversation if the teen is not willing to. Now, I'll also tell the teen at that point that sometimes it's helpful to have parents on board, and I might try to navigate that with them or encourage them to do so, or weigh the pros and cons of that and talk how we can support them in using their parents as a helpful resource. And I let parents know that I'm not going to breach their teen's confidentiality unless there is some imminent or serious risk present, which I would say is pretty similar to the 5 criteria that I had mentioned earlier, with a little bit more wiggle room around that kind of imminent risk piece. I might consider imminent a little bit further out, especially with teens having a disposition for more impulsivity due to their developmental stage. Next question is, how might suicide interventions differ in a residential treatment setting? Suicide interventions differ quite a bit in a residential treatment setting. Residential treatment is an area in which I have not worked myself, so I don't know that I'm the expert in this question, but I would say that residential treatment settings are often, and to just parse out residential versus emergent hospitalization, I'm talking about residential in the sense that it's like a longer term stay, typically a month to 3 months. Residential treatment is really about helping people have the tools and the ability to survive long enough to engage in a step down level of care post discharge from residential, which means that we're really focused typically on making sure that person has the tools to tolerate emotional distress, to tolerate prompting events or common factors that precipitate suicide risk, and then making sure that that person is able to then discharge into a lower level of care where they can continue to practice those skills in the environment in which that risk occurs. One of the challenges with residential treatment is you don't always have the opportunity to practice new learning and new skills that you would get from mental health services outside of a residential treatment setting while you're in it. Thus, it's really encouraged that that residential treatment setting is about getting the necessary foundation to be able to successfully move into other treatment post-discharge. The next question, is there helpful training available for first responders who are not mental health professionals to learn how to best work with people with suicidal thoughts and behaviors? I find that the collaborative assessment and management of suicide model is quite accessible to the layperson, even if you're not a mental health professional. You might not go and do the whole certification process, but I find that they have really effective interventions, but it's not designed for the layperson. I think it's just a very informative training. But as far as lay people, I think mental health first responder training can be quite helpful. It's not going to be specific for suicide, but it does often include components about helping understand suicide risk. But those are the only things that jump to the top of my mind for this question. But I would love to get curious and learn more. So maybe that's something for me to look into. Would peer support group be appropriate in school setting, or would it make it worse for students? I think as far as a peer support group specifically for suicide or self-harm risk, that will vary quite a bit depending on the level of support that the students have. One of the things that we have to be mindful of is with that developmental stage, depending on how old the students you're referring to are, contagion can be a real risk factor, and there can be some ways in which students can encourage or reinforce suicide risk, especially in this day and age. We're seeing a lot of students create relationships that are around identities with mental health and suicide and self-harm risk, and often include use of online content like Twitter feeds, Tumblr feeds that kind of glorify or highlight or give examples of self-harm or suicidal behavior. And so one thing we want to be mindful of is that the environment is really supportive, appropriate to that developmental stage, so that it doesn't turn into a social support system or relationships that are around that identity outside of the support group. So you might be specific about how they know each other outside of school, what's appropriate for who's in the group, are there dual relationships, what are the ways in which we model talking about those behaviors in the group setting, is it led by a licensed professional that would be able to assess that risk? And I think broadly speaking, I know schools tend to be more liability minded and tend to really discourage talking about suicide or self-harm risk without any sort of intervention present, so connection to mental health resources outside of the school, parent information, so on and so forth. So it might also make it challenging for people to be able to openly talk about it depending on the school's policies. But I wouldn't say that it's inappropriate. I think it just has to be done in a very intentional way. The next question is, curious how many people on your caseload have identified problem with suicide and what number of them you recommended hospitalization, specific to the criteria that I mentioned. I would say in the last 2 years, I actually have not recommended hospitalization once. I have had clients hospitalized, and I've helped them through that process, both going to the hospital, during the hospital, and post-discharge. But I will very rarely recommend hospitalization. And I think part of that is most of my practice with highly suicidal people is in the context of DBT. And in DBT, we tend to really discourage hospitalization not only for the research, but also because hospitalization can sometimes be reinforcing of suicide risk, especially if hospitalization provides a relief, even if temporary, from the stressors of that person's life or the context that prompted that escalated suicide risk. And what we want to avoid is reinforcing the idea that hospitalization gets you a break from that rather than encouraging how we skillfully cope with those situations. Now, hospitalization is typically, I would recommend and have recommended hospitalization in the past when someone is still learning skills and doesn't have the tools necessary to be able to cope with the current stressors that have led to elevated risk in a meaningful way. And I need to help them stay alive long enough to get them those tools. Sometimes hospitalization is recommended to help with more emergent or immediate medication stabilization concerns relating to perhaps symptoms of like psychosis or significant changes in mood or mood disorder related symptoms. Um, but or there's some real high risk without any willingness to safety plan, like a firearm present in the home, imminent threats, and suicide is on the table. That's often when hospitalization feels like a necessity because the risk is so high that there's no other option. And then the last question is, how do school social workers who are required to inform parents when there's a suicide disclosure of any kind protect students from experiencing negative consequences, especially if the breach in confidentiality is non-collaborative because the student does not want the parents to know? Really love this question. My partner works in schools, and so I'm very familiar with what it's like to work in the school environment. And one of the things that's really important in situations like this is that we try to make it as collaborative as possible. A helpful way to frame this conversation is just recognizing the reality, which is now that you've disclosed this, per the school policy, these are the things that I have to do. Now, within what I have to do, here are all the options that we can take to get there. Can we spend some time talking about what you want to prepare for that conversation? What you want to say? Do you want you to say it? Do you want me to say it? Do you want anybody else there in the room with us? Are there things you're worried about your parents doing or saying in response to this, or to other staff or faculty doing in response to this? How can we plan for how we want to navigate that? What do you worry will happen as a consequence of your parents knowing? Are there ways that we can make sure you have services or supports or plans in place for that? How is this going to impact you and I's relationship? Talking about how the ways in which now they've realized that there's this disclosure necessary, that might change how they talk to you or what they share with you, and really just putting that out there and saying, like, it makes a lot of sense that this might change how you communicate with me. Can we talk about the pros and cons of that and how that may impact our work together? So really recognizing the things that you can't change and then trying to get as flexible and supportive as you can with all the other things, and kind of thinking about on the slide of the consequences that often happen for adolescents who have an involuntary breach or disclosure, looking at each of those consequences around hopelessness, impact on the therapeutic relationship, trust in mental health services, really almost looking at that as like a checklist of how can we make sure that we're touching on all of things and planning ways that we can mitigate how this might impact our working relationship and what happens as a result of this. All right. I think that's all the questions.
Awesome. And yeah, we could do this all day. Unfortunately, we can't. But I want to thank you, Josh, for like just you did everything that I knew you were going to be able to do and more. I'm just so grateful that you were here to share your expertise. It's a challenging topic, but I'm confident that people are going to walk away from this presentation with a more thorough and thoughtful perspective on how to bridge some of these critical gaps. So I really appreciate you taking time to share your expertise with us. And to everyone who joined us today, thank you for being here. For attendees seeking CEUs, please watch your email in the coming days so you'll get a link to the presentation and a brief quiz. And then once you successfully complete the quiz, you'll get an automated confirmation of CEU hours. You can find video recordings, CEU quizzes, and details about all of our events on the college event page, which is now being linked in the chat. As well as we've reopened our previous Beyond the Classroom or maybe in Grand Challenges event, talking about issues of working with men who are experiencing suicidal thinking. And with that, I want to thank everybody for being a part of today's event. Be kind, be safe, and be well. And again, thank you, Professor Kivlovitz, for joining us today. We really appreciate your expertise.
Thanks all for coming. This was a treat.